So we'll just try and briefly understand what are the definitions of a child with chronic cough, what are the different types of cough which you will find in clinical practice. We'll also try and talk about specific cough pointers, right? So specific cough pointers are indicators of an underlying disease which this child might be having. But majority of the patients you will find who present to you in the OPD, they do not have any signs which they or which indicates a severe problem. So how do you evaluate these children who come to your OPD and when their cough is not getting better? So from where do we get these definitions of chronic cough, right? So there are no studies which have clearly defined when we should call cough as chronic, right? What we usually find is that children who have upper respiratory tract infections, most of them will improve. So 50% improve in 10 days, and in 25 days, approximately 90% would improve. And hence, most countries and most guidelines have defined chronic cough as a cough which is more than 4 weeks of duration. The problem is that in India, because tuberculosis is significantly more common, and we have to keep definitions in sync with our guidelines. Previously, it used to be 3 weeks, but now we take it as 2 weeks. So for the Indian setup, we would still take it as 2 weeks. Now, what do we do with a child who presents to us in the OPD? Right, so try and see whether this cough is recurrent or persistent. Try and look at the type of cough, look at the markers of severity or markers of severe disease, and then you look at other clinical clues to etiology. Now, these graphs tells you about a pattern of cough. So as you can see here, this is for a 4-week duration. This is for a 4-week duration. You can have cough which is acute in onset and then gradually improves, right? But you also have a cough pattern which is recurrent, so it comes, it improves, again comes and again goes. So this is a recurrent type of a cough, and you have a third type of cough which keeps going on or gradually gets worsened. So these are 3 different types of characterization which you will see in clinical practice. Acute cough with delayed recovery is more associated with viral infections. Recurrent is more associated with either recurrent viral infections or it is associated with asthma. A persistent non-remitting cough is something which is more important, and in few of these studies, it has been related with tuberculosis as well. But it is the persistent non-remitting variety of cough which you are trying to evaluate further. Now, these are different types of cough, and you learn these gradually as you do clinical practice. So it can be a dry cough, it can be a productive cough. So in an older child who can bring out phlegm or sputum, you can have productive cough. Now, younger children still have phlegm in their airway, but they can't bring it out. So you don't use the terminology productive. You use the terminology as moist or a wet cough. And that moist or a wet cough is a marker of an underlying disease like a bacterial bronchitis or a suppurative lung disease, and we'll talk about it. And children sometimes can have a spasmodic type of cough which has a prolonged expiration. You can have a rattly cough in children who have recurrent viral URI, and parents are able to feel these rattles. You can have a classical whoop which is there, which gives you a diagnosis. You have a croupy cough in children who presents with croup. You can have a classical honking character which you find in children who have habit cough, and you can sometimes have a barky cough. Now, understanding these types of cough and how they would appear can give you a clinical diagnosis in no time. So it is important to understand how these different type of coughs would sound. So as I said, wet cough is when secretions are there in young children, but they can't bring it out. And at that point of time when children are coughing, they have a different type of a sound which is there. And there is significant amount of data which has been published on this, especially from the group from Anchang from Brisbane, which talks about wet cough and how parents can actually be very helpful in telling you that my child has a wet cough, and they're usually right. So once you listen to a few wet coughs, you will understand that how wet coughs appear, and it is important to recognize this entity in clinical practice. Children who have a persistent wet cough, so we are not talking about a 5-day cough or a 7-day cough or a 10-day cough, but if children have a persistent moist cough which keeps on moist and they do not have any other specific cough pointers, then you can consider this as a protracted bacterial bronchitis. This entity has been described from the West. We don't find so much of PBB in the Indian setup, possibly because we are overusing antibiotics. And the treatment for this is usually Comoxiclair for 2 weeks. And this bacterial bronchitis can progress to a chronic suppurative lung disease and can end up into a bronchiectasis. And that is the reason why recognition of this entity and actually recognizing something known as wet cough is there is important. Now the next point is what are specific cough pointers. So these are signs, symptoms, or radiological manifestations which are based on expert opinion, and they usually indicate a serious respiratory disease. Now, these are cough pointers, and there can be many more. As I said, it is not evidence-based, it is based on expert opinion. So what paper you get, what guidelines you are reading, you can have different cough pointers. But daily moist or productive cough, presence of failure to thrive, digital clubbing, hemopsis, recurrent pneumonias, chronic dyspnea, persistent auscultatory findings, cardiac anomalies, immune deficiency, a prolonged cough more than 6 months, swallowing problem, presence of low-grade fever, weight, and loss of appetite. So these are some cough pointers, specific cough pointers which you need to recognize. So I'll just go take you through a few cases which will help you to understand how we go about it. So this is a 1.5 years old boy, otherwise seems to be well. The parents come in with a history of chronic cough since birth, so that is something which is sinister, and it happens with feeds, right? So you're thinking in terms of either a laryngeal cleft, an H-type tracheofacial fistula, or aspiration from the glottis, right? So the examination which is needed is possibly a bronchoscopy. We went ahead, examined, and this is the trachea, and we are trying to come up. We are trying to look at an H-type of tracheoesophageal fistula. Now, as you come up, these are more cervical fistulas which you see later in life. And once you identify a fistula, so you can see a dot coming here, something here which is fishy. So you try and put in contrast into the esophagus and see whether it is coming out through the tracheal end. Right, so we usually use diluted betadine, some people use methylene blue. So you will see contrast coming out from here. So you can see that betadine is actually coming out through the tracheal end. So that confirms that this is not just a mucus tract or a diverticula, it is actually a fistulous communication between the trachea and the esophagus. Right, so this 45 days old infant presents with chronic cough since birth, fast breathing for a month. Well, you know that something is going on. This is not a normal cough which you would see day in and day out in practice. There is no fever. Now this child is not gaining weight, was 2.5 kgs at birth, still is 2.5 kgs. You don't find clubbing, but they're bilateral conducted sounds, right? X-ray shows some amount of hyperinflation bilateral lung fields. You repeat an X-ray when the child comes to you and you find a small collapse here. So if you find a small middle lobe collapse which is there, definitely you're dealing with something else which needs to be evaluated. The most common differential diagnosis would be some congenital problems. And because it is more of cough than rest of the findings, and there is significant failure to thrive, I think cystic fibrosis should be up on the cards. The bronchoscopy shows mucopurulent secretions, it grows pseudomonas, you're almost confirmed. You do a sweat chloride which is raised, and delta 508 is positive. So again, young infants, think of congenital problems, think of genetic disorders that can present as chronic cough. Now this 1-year-old has cough and noisy breathing and respiratory distress for a month. Has no significant fever. Now, there is history of eating cucumbers and choking on cucumber. It is very weird because it is something which is soft, and we haven't seen such a soft object getting aspirated into the trachea. Now, this child gets admitted 3 times, gets antibiotics and bronchodilators, goes home. The parents are very clear that noisy breathing is persisting. So there's something in addition to cough which is making you think that you possibly have a different diagnosis here. These are not just viral infections. You have three sets of X-rays. All X-rays look normal, except that there is some amount of hyperinflation which can be appreciated. So what's going on? Are you missing something? Right. So sometimes you have airway problems, especially in the trachea, which may not give you findings in the X-ray, and children can have significant problems. The most common being a foreign body in the trachea, which can be missed. You can have other problems like a tracheobronchitis as well. So this child underwent a bronchoscopy, and I'll just show you a small clip. So as we enter into the trachea, you find a piece of peanut. So this child had a history of eating cucumber and choking on a cucumber, which is quite rare. And this is actually a peanut which parents never realized. So this is a tracheal foreign body, and because these tracheal foreign body do have some space around them, air can go in and come out. That is the reason why you can have normal X-rays, and you can see a Doppler basket being passed through a flexible bronchoscope, which aids the extraction. Right. So most of the foreign bodies, the way we do it in the PICU, usually in sedation, and makes the procedure quite easy, but people can do it differently. So again, presence of a monophonic wheeze which is persisting, and a child who is unwell makes us think that you have something in the background which is going on. So this 8 years old has again fever and cough, right? Receives a course of comoxiclav, X-rays done. The person who treated thought these X-rays are normal. If you look at these X-rays, you can see there are some shadows here and possibly a doubtful lymph node here, but you're not sure. Now this child, when comes in follow-up after 2 weeks, the fever is persisting, the cough is persisting, and this child has lost weight. So again, something more than cough is there, which is keeping you alive. That something else is going on. Now, if you look at these X-rays, then the radiological opacities have definitely increased. So patchy opacities in the upper lobes, a possible node in the left hilar, makes you think that something else is going on. So with this history, you need to evaluate these children further. GAs were done, they were negative. We had a high suspicion of tuberculosis. This child underwent a bronchoscopy, and the gene expert was positive. So again, tuberculosis can present with chronic cough, it can present with fever which is there, it can present with weight loss, and it can present with non-specific shadows in the X-ray. So you always may not have miliary shadow or cavitatory lung disease or hilar or mediastinal nodes. Right? So that needs to be kept in mind. And that is the reason why, as I said, we still keep the definition at 2 weeks. So this 10 years old boy has cough for 2 or 3 months, gets fever off and on. Counts are raised. So these counts are not normal. These counts are like 30,000. Why are these counts high? And you have an X-ray here. Now, if you look at these X-ray, then this X-ray is definitely not normal. You definitely have nodular shadows which are there in the bilateral lung fields. You can have a closer look here. What was not done was a differential count, and when we got a differential count, the absolute eosinophil count was 28,000. The most common differential diagnosis in the Indian setup remains as filaria. So this child actually has a tropical pulmonary eosinophilia, and even the antigen was positive. How about this child, 12 years old girl, fever off and on. There's no anorexia, weight loss, and a MANTU which is positive. Right, so everyone thought this is tuberculosis, a possible left hilar node, and a left-sided patch. Now this child, this is the X-ray of this child. This is the close-up of this X-ray, and this is an X-ray which was done 5 minutes later. Right, so this X-ray, the opacity has disappeared. So if you compare these two X-rays, what exactly has happened is that this is the opacity there, and this opacity is not here. Why has this happened? Because actually it was a hair bun. Right, so it was a hair bun or a hair braid, which was actually leading to confusion. So sometimes your specific cuff pointers can lead you the other way as well. So be careful about these. We had a child who had a long hair braid, and there was an X-ray shadow like this, which was coming across and going up to the diaphragm, and no one knew what happened. This child underwent a CT, and then that CT was normal, and then people realized, even the radiologist realized that actually it was a hair braid. So these specific cuff pointers which you are trying to evaluate can sometimes be misleading. So be very careful about these things. So what is the possible set of differential diagnosis in children who have any of these things in addition to cough, right? Now, it is a very large set of differential diagnosis. Whole of your pediatric pulmonology, is chronic cough. You can have congenital problems, you can have aspirations, you can have suppurative lung disease, you can have foreign bodies, you can have anything else which can present with chronic cough. So it is, you can't have just one set of differential diagnosis. You need to evaluate these children further, and hence you cannot have a set investigative pattern. The pattern of investigation actually depends on, what the disease entity appears to be. So whether you want to do a CT first, or a bronchoscopy first, or a sweat chloride, or an immune globulin level, or an HIV, actually depends on a case-to-case basis. But how about children who present to you in the OPD but who do not have any other signs? So for example, this child who is 7 years old gets recurrent episodes of cough for the past 4 years. Obviously it is not normal. Each episode is a bit prolonged. The child remains well, has a recurrence, responds to oral salbutamol. This child comes from a village setting where they don't use nebulizers as frequently, but you will get a lot of patients who gets nebulized. It is more in season change. It's more early morning during exertion. Now the problem is that you don't have any specific cough pointers. The examination of the chest appears to be normal. Now these are the situations when you need to evaluate these children further, and the most common group of disorders would be something related to asthma, but there are other differential diagnoses. I'll talk about it. So can this still be asthma? Well, definitely. This child undergoes a lung function. You can find a pre and a post bronchodilator curve, where this is the pre and this is the post. And you can find that these curves are obstructive. You have values here which shows FEV1 by FVC ratios which are low. You have these values which are low, and you find reversibility in FEV1s. Right, so asthma is something which can present with chronic cough, and asthma can present even without a wheeze. So that's a very common differential diagnosis. So what next? You have a 5 years old with suspected asthma, cannot do a lung function. You have a 3 years old with chronic cough. I don't know what needs to be done for this child. What you can do is you can use computer animations to get a better curve on a spirometry. That is definitely possible. You need to spend some time with these children, which is that's quite fruitful. You can also consider doing an impulse oscillometry, which is a newer diagnostic technology. So for example, this child 5 years old with asthma, suspected asthma, you can find that the R5 values are significantly high as compared to the R20 values. So it was showing a peripheral airflow obstruction. And similarly, this 3 years old with chronic cough but no wheeze, what should I do about this child? Should I put this child on a nail corticosteroid? Is the family happy or not? So again, this child shows an obstruction, so 138% here, and you can find a 35% reversibility in R5 and 60% reversibility in AX. So asthma is an iceberg, and these things are commonly seen in clinical practice. So you can have partial manifestations of asthma, just with wheeze, just with cough, just with breathlessness, only exercise-induced symptoms, and that can be a bit more confusing. Now, children who have chronic cough, but they do not have any specific cough pointers, and that would be the maximum population, which I'll just finish in 2 minutes. I think I have 2 minutes there. So, a chronic cough with no specific cough pointers. I think this is the maximum number of patients you will get in the OPD. Khansi hai, khansi theek nahi ho rahi hai. Everyone is fed up with that, and on examination, the child looks okay. They have 1 or 2 X-rays which seems to be okay. They have got a CBC count and a CRP and so many things which all seems to be normal. So what is the possible set of differential diagnosis which you will be looking at, right? So this is what I think should be the differential diagnosis. The recurrent URI or nursery school syndrome. So back-to-back URI is sometimes they remain well in between, sometimes it overlaps, and that is a common differential diagnosis. You can have a post-viral cough. So a parent coming at 3 weeks or 2.5 weeks or 2 weeks, cough not getting better. It seems to be an acute cough with a delayed recovery, so that's another common differential diagnosis. You can have cough variant asthma, or the wheeze was missed, right? If the child is not wheezing today, it doesn't mean the child wasn't wheezing 2 weeks back or 4 weeks back. So it is possibly a wheeze which we are missing at this point of time. So that is again a very common differential diagnosis. The other things which are commonly seen are chronic rhinosinusitis and allergic rhinitis. So we see a lot of patients who come in with persistent throat clearing, a wet type of a cough, and something trickling down the throat. You examine them, you find a postnasal drip. They're more coughy at night. They're not wheezy. Their lung functions are normal. But sometimes you can have allergic rhinitis along with asthma, so that can be a bit confusing. But that is a common differential diagnosis which you would see, and they just need to be treated for the upper airway. Habit cough, classical honking cough, never at night, pertussis, definitely seen in clinical practice. GRD related cough is something which is more exaggerated in clinical practice. It is more related to adult practice. We see children with GR, but they would usually be not just cough, it would be wheeze and pneumonias and so many things. And then bacterial bronchitis and a set of suppurative lung disease. Right, so this is the set of differential diagnosis I would be looking at. How do you evaluate these children? So the chest X-ray is something which is definitely recommended, at least one. I'm not saying get an X-ray every time. A lung function is something which is quite useful. So good quality spirometry, plus minus IOS depending on the availability. And if the child seems to have a persistent